Was a bus driver driving bus for more than 1000 kilometers. He had high velocity trauma on highway in August 2024. He was taken to some local hospital, and at this hospital he was treated like this. He presented us with this x-ray in February 2025. He was a non-smoker with no comorbidities. Clinically, he was not able to do SLR, not able to walk freely. He had shortening in right lower limb with no signs of infection. Blood markers were normal in view of infection. MRI was done, the head was viable. So the functional problem with this was pain in hip and thigh. He was having difficulty in weight bearing. There was 1.5 centimeter of limb shortening. Radiological challenges were sclerosed margin in the segmental shaft femur with non-union and this Pauwels type 3 neck femur fracture. It was neglected. Now the management challenges were high avian risk in the head, poor bone biology as the margins were sclerosed, and non-union was there, as well as the mechanics was not good as the proper fixation was not there. This is a paper of European Journal of Orthopaedics. It was showing multiple complications in segmental shaft femur fracture. As well as due to neck femur fracture neglection, he was having limb line discrepancy as well as biomechanical instability. Patient was high demanding young patient, and chance of infection was there. Now we planned for two-stage surgery. In first stage, we planned for implant removal, and we wanted to address segmental shaft femur non-union. We did freshening of sclerosed margin, cortical decortication and then we did reduction, open reduction with tension band, multiple tension band, and did proper size distal femur nail and cancellous bone graft which was impacted in the fracture. And in the second stage, we planned according to Sandhu's criteria. Dr. Sandhu presented a paper long back for salvage of neck femur, and we planned according to that and planned for lateral closing wedge intertrochanteric osteotomy and fixation with 120-degree ABP. So this was first stage. We did in supine position, removal of implant, then opening of the fracture site, proper reduction, cancellous grafting, decortication with the burr, saw and osteotomes. We did shingling. We used polar pins for proper reduction. This was APU of lower segment, upper segment in the IIT. This was immediate post-op. Here, the fracture was reasonably reduced and it was fixed with proper mechanics. On 7th post-op day, this was the clinical picture. Wound was healthy, so we planned for second stage. This is the ABP and osteotomy planning. We planned for converting 65 degree of fracture in 25 degree so that we can convert shearing force into compression force. This is a paper of Dr. Ashok Gavaskar. So these all our calculations. This is second stage. First we did CC screw for stabilization of the fragment. This is final position of chisel. Then we plan for osteotomy, which is marked by 2 wires. We removed the wedge. We inserted 120-degree blade. Then we overlap the plate and nail screws. We would able to do only 2 screws in the plate and another tension band for holding the plate. This was 3-month post-op X-ray. Sorry, this was immediate post-op. 3-month post-op showing signs of union in the segmental as well as neck femur part. Functional outcome at 3 months. Patient started driving bus from Jaipur to Hyderabad after 3 months. This was 6 months. At 6 months, he was having excellent function. He was able to climb stairs, walk freely. This was 9-month post-op in November. And now onward, we have called him for every 6-month follow-up. Post-operative management was early mobilization, DVT prophylaxis, then monitoring of infection, AVN, and limb length discrepancy. If there is any, we would have to give shoe raise. Summary: in all the segmental shaft femur fracture, we have to plan properly. We have to use proper size of nail. Proper reduction is mandatory before any and do screening in IIT for any neck femur fracture. If untreated and missed neck femur fracture can be treated later on by Sandhu's criteria for salvage or replacement. Thank you.